evening, everyone. At the outset, I would like to thank chairperson and organizer to give me this opportunity to speak on my work on transjugular kidney biopsy in cirrhotic patients. Kidney biopsy is a very magical tool for diagnostic purpose, for nephrologists, for therapeutic, and the prognostic. We all know percutaneous method is always preferred and the yield is more than 95%. Then why we are talking about the transjugular kidney biopsy today? Yes, we do need transjugular kidney biopsy in patients who had abnormal coagulation, who are on warfarin therapy, who had single functioning kidney, who had simultaneously like patient who had liver problem and kidney biopsy also, and simultaneously we can do both the biopsies. Patients who are uncooperative, who are confused, who are ventilated, and who had known renal microaneurysms. If we go back to the history, how it got invented, the first transjugular renal biopsy was performed accidentally in 1989 by Frederick Moll, who carried out a transjugular liver biopsy, but surprisingly, he received a pathology report describing a sample of renal tissue. If we talk about the diagnostic yield of transjugular kidney biopsy in the literature, it is 73 to 90%. Complication reported is 2.7 to 27%. In the form of capsular perforation in the 60 to 90%. But this capsular perforation is not clinically related to the poor outcome. It's just the capsule elevation and you get the more cortical sampling, more glomeruli in this. Perinephric hematoma, gross hematuria, and some 1 or 2 cases of renal vein thrombosis probably due to the mechanical problem to the renal vein. So this was the study design in my, if you'll see, sorry. So this was the study design. We retrospectively review all the patients who underwent transjugular kidney biopsy from June 2013 to June 2016. All patients with chronic liver disease with associated kidney dysfunction subjected to the transjugular kidney biopsy. We did both fluoroscopy and the transabdominal ultrasound guidance also simultaneously in 28 patients. We looked at the number of passes taken, we looked at the number of glomeruli, we also looked at the adequacy of the tissue core and histopathological examination. Primary research question was the safety and the diagnostic yield of sample, and second was to determine the incidence and severity of complications. Indication in my group of patients, patients who had proteinuria and active sediments, patients who needed both liver and kidney biopsy, and patients who were standing in the gray area like GFR 30, and we have to decide whether pediatrician should go for the SLK, simultaneously liver kidney transplantation, or isolated liver transplantation. This was a routine check before the biopsy, routine hemoglobin, PTINR, and platelet count, and we did the ultrasound of the kidney in all the patients next day morning in order to look for any perinephric hematoma. If somebody complains the pain or any other complication, we do frequently monitoring of the ultrasound 2 days, 1 week, and 1 month after the procedure. So this is the 3D diagram of the kidney biopsy. If you look at the, this pointer is not working. I can show you otherwise. Can you show me? So this is the kidney biopsy set. You can see this is the Thomas, made by the Thomas company, and this is the main kidney set, 70 centimeter long, 18 gauge. This is the metallic cannula. This is the multi-purpose catheter. And if we see, actually, first we puncture the internal jugular vein, and this is the IVC. And when we put the multi-purpose catheter, after putting the sheath, then the multi-purpose catheter is put, and this is the renal vein. We put 2 to 3 ml of the contrast, diluted contrast, to check the renal vein, whether we are into the renal vein. And after this, we insert the biopsy gun, and this is the throw length of the biopsy, and this is the metallic cannula. This throw length is 2 centimeter. We should not go beyond 2 centimeter because otherwise there will be the complication in the form of perinephric hematoma. This is again simultaneously we do the ultrasound also. One operator is standing with the ultrasound and one is doing this biopsy, and this is the throw length of 2 centimeter. And if we look at the results and the observation in our study, and all the patients have severe coagulopathy. More than 50% patient had INR more than 1.5, platelet count less than 1.5. If you look at the needle passes, it was roughly 2 to 6, and the mean was 3.6. Length of tissue core was 0.4 to 2.5 centimeter. Mean was 1.2 centimeter. Number of the glomeruli was 0 to 17. You can see in the initial phase of our learning, we hardly get the sample, like number of the glomeruli was 0 to 4. But later on, it reached up to the 17 also, and the mean was 6.7. This is the histopathological diagnosis. We can see the various. The most common was IgE nephropathy, followed by MPGN and amyloidosis. And this is about the other results. Adequacy in our study was 86%, like 20. We received the sample in 24 out of 28 patients. Minor complications was seen in 33%. Minor complication in the form of little pain at the loin pain, and macroscopic hematuria in the 5 patients. Capsular perforation seen in 40%. But this capsular perforation was not related with the clinical poor outcome. It is just a finding, like we see the contrast was going out, and perinephric hematoma was seen in 11 without any poor clinical outcome. And this is the pericapsular extravasation contrast. Only 3.7%. In one patient, we have to do intervention, and this is called the major intervention, like we have to do the coiled embolization. But in this particular patient, he required 6 number of the passes, and recommendation is you should not go more than 4 passes. Takeaway point is that transjugular renal biopsy is a relatively safe and effective diagnostic tool in high-risk patients with coagulopathy who require renal tissue for accurate diagnosis. We can use combined fluoroscopy plus ultrasound. Seems to be more safe if we see the throw length is going beyond the cortex. But one should weigh the benefit versus risk. We should select the patient carefully. It is not recommended for all the group of patients. And it depends upon the technical expertise of the operator also. You can see in my results also, initially hardly were we getting any glomeruli, but later on, after 4 or 5 biopsies, we were getting around 17 glomeruli. Yield is more and less complication if minimal passes. It has been seen if the number of the passes is less than 4, you'll get more the cortical sampling. More the number of passes, more chances of bleeding, more touching to the arteries, and probably you're getting more medulla also. There was minimum chance of contrast-induced nephropathy. We hardly give contrast, just give 5 to 10 ml. Thank you so much.
Sorry, Mr. Chairman, we will not be able to take questions for this paper as it has crossed the entire 7-minute schedule.
Thank you.
With this presentation, we come to the end of this session, and in a few moments we will come with the results.